Okay, well, good afternoon, everybody, and to Rebecca, who's our guest speaker today, good morning. So we have the privilege, and this is one of the wonderful things about Zoom and this virtual world that we live in nowadays, is we get to connect with people all over the world. And today we're getting to speak with Ms. Rebecca Black, who's joining us from Sydney, Australia. It's wonderful. So very excited to talk to Rebecca. We've been waiting to host her here for a little while. And she wrote a very nice paper in the Journal of Heart and Lung Transplantation on swallowing and laryngeal complications following heart and lung transplant. And something that we do see often in our patients, who are undergoing transplant, heart and lung transplant, post-operative complications that could involve their inability to swallow very well afterwards. So, sorry, I'm sitting in a public place and people were trying to talk to me, not knowing that I was in the middle of a meeting. So that's why I got distracted there for a second. So Rebecca is a speech pathology clinical specialist and researcher working at St. Vincent's Hospital in Sydney, Australia. Rebecca has been working in critical care for over 20 years and is the Australian speech pathology clinical expert in the area of heart and lung transplantation. Rebecca is widely published in the field and is currently conducting her PhD through the University of Sydney with a focus on swallowing and laryngeal dysfunction in heart and/or lung transplantation. So again, very excited that Rebecca's here to join us today. And Rebecca, please go ahead, and the floor is yours.
Thank you so much for that lovely introduction, Michael. Can everyone hear me okay? Excellent. There is a little bit of an echo or background noise from your end, so if everyone could just mute their microphones, that would be greatly appreciated. Thank you so much. I'm really excited to be here. This is my area of passion, clearly, and that I'm doing my PhD in the field. Always an interesting and challenging journey at times. But I'm really probably mostly excited to obviously share this research with you, but also to hear about what you guys do at your end, which would be fascinating going forward. So as Michael said, this is a joint presentation between University of Sydney and St. Vincent's, where I have been working for many years. I'll give you a bit of a backstory. So I started at St. Vincent's about 12 years ago now. And as Michael said, I have been working in critical care for a really long time, but this was my first exposure to heart-lung transplant. And in Australia, we don't, as speech language pathologists or speech pathologists, as we call ourselves here, don't have a huge kind of role or we're not kind of known frequently in this field. So even though I'd been a clinician for a long time, it was fairly new to me. And so I was obviously noticing a lot of patients having lots of issues with laryngeal complications and dysphagia. And I was thinking, oh, okay, this is a bit more than I would have anticipated. And so I went to do and was really shocked to find that there was a huge paucity of research out there. So hence started on this journey. And I'll take you through where we are as a research group to date and what we're looking to do in the future. I don't know if any of you know some of the research team that I work with. I've been very, very fortunate to work with some amazing people. Professor Peter McDonald is our senior staff specialist in heart failure transplantation here at St. Vincent's. He's quite internationally recognised in the field. And previously, I was working quite closely with Professor Alan Glanville, who's very well known in the lung transplant field, but he has recently retired. So I'd just like to acknowledge all of the amazing people that I work with. It's mostly across Australia and New Zealand. And it's the faculty of medical staff, obviously, and speech pathologists and academics. This is where we are. This is St Vincent. So I thought I'd give you a bit of an idea of where we're located. I don't know if any of you have been to Australia. Michael and I were just having a bit of a chat about our coffee addiction. Excellent coffee if anyone wants to go all the way to Australia. So St Vincent is located right in the centre of the city, which means that we have a very interesting demographic. As you can see, our beautiful opera house. Just to give you an idea, St Vincent's is actually only about 5 minutes drive away from Sydney Opera House. So come and see us. But what that means is being, we're in the inner city like any other city in the world. We have some issues with homelessness and drug addiction surrounding the hospital. But then we also have some extremely affluent suburbs, obviously being so close to Sydney Harbour. So it makes for quite an interesting demographic in terms of our patients that come through the doors. So you've got, the richest of the rich and then the very poor and vulnerable. And just keeping in mind, Australia has, we're very much, it's a public hospital policy. So although we're Catholic healthcare, we are a public hospital and thereby patients do not pay anything for all the services they receive. And they don't need to be privately insured or anything like that. So, yeah, it's basically anyone and everyone is treated depending on what they require, as long as they're an Australian citizen or a permanent resident. So it'll be interesting to talk about the differences with your transplant service. So let's look at heart and lung transplantation at St Vincent. So we're one of only 4 heart and lung transplant centres in the whole of Australia. And for those of you who know Australia, it's a pretty big, pretty broad country. And we're actually the only centre for our state of New South Wales and the state of South Australia. So I'll show you what that looks like in a moment on the map. So we're covering a population of about 10 million people. We're fairly much considered a leader in transplantation surgery and clinical research, and our patients travel to see us for a lifetime follow-up at St Vincent. So, yeah, we get to know them very well. So this is Aussie. You can see New South Wales there in the bottom right corner, so a fairly large area, and South Australia just to the left. So fairly large area that we cover. So it's quite, you can imagine, pretty intense for some of the patients to relocate all the way to New South Wales when they got the call up for their transplant. So to give you an idea before we launch into actually looking at laryngeal complications and swallowing in our patients, have a look at our activity data. And again, this will be interesting to compare with you guys. So we've only got the figures here up to last year. And you can see, so about 48 hearts, 56 lungs. So we're looking at about 100-ish across the last kind of, prior 4 years to this point. COVID was interesting. You can see we still kind of maintain numbers there, but it was certainly a challenge like everywhere else. All right, so what do we actually provide our patients from a voice and swallowing point of view? In Australia, speech pathology isn't really commonly involved before transplant, so we're not really commonly involved in that workup phase, but that might be changing. And as I said, I certainly noticed when I started a long time ago the really high rates of referrals following extubation for voice and swallowing issues. So what do we provide? Like any other patient that's referred, certainly we would provide a bedside voice and swallow assessment, and quite commonly a fibroendoscopic examination of swallowing, and then a video fluoroscopy if indicated and if it's possible for that patient. We have really close relationships with our ear, nose and throat surgeons, and certainly refer for review if we're concerned about vocal fold function. But the other thing I was noticing was that the patients that I was seeing were certainly reporting a really large impact of these voice and swallowing issues, both on their physical and emotional recovery. And I think the nature of this patient population, in that they're often, can be, young in healthcare, being, under the age of 60 potentially, and some, patients coming through in very young, 20s, 30s, and the impact that has on their ability to function, both socially and emotionally, when they're struggling to speak and struggling to swallow. And as I already mentioned, very minimal literature available to date. So why do we care? Obviously, I'm preaching to the converted with you guys, but our patients, they're very poorly when they're coming to us for transplant. They've got poor reserve, they're really frail. After the surgery, obviously they're, compromised respiratory function post-extubation. So we're very concerned about that breath swallow coordination issue and the impact that will have on their swallow function. Again, there's certainly potential for laryngeal dysfunction, and we'll talk about why that is, with associated effect on the glottic function and the aspiration risk that can cause. And clearly, they're immunosuppressed. They're not the kind of patients we want to be aspirating, absolutely not. So in terms of our journey as a research team, let's have a look at what the data actually tells us. So I think it was 2019, we published this systematic review as a basis for starting this research journey. The evidence was scant. I think there was about 5 papers back at this point, but the papers were showing a really high incidence of dysphagia, lots of silent aspiration reported. And, the rates of vocal fold palsy were very broad. You can see there 2.9 to 34, a bit of a strange range there. But obviously, because the data was so scant, it's hard to get any incidence figures. But normal swallow was definitely suggested to be associated with significantly improved survival. So this was an interesting jump-off point for us. And we were thinking, wow, okay, the rates are really high. There's lots of concern there. Let's dive a little deeper. So this started our journey on a retrospective review. And in this study, which was again published in 2019, we were really wanting to find out if we could identify any particular clinical predictors, which patients were more likely to develop dysphagia and laryngeal dysfunction after the transplant. So we had a cohort of about 284 patients, and we found that 24% of those were actually referred on to us. So that was pretty high, a quarter of the patients. And then what we did was an analysis of the demographics and the pre and post-operative variables and looked for any association with referral to speech pathology. So what did we find? So it was majority lung transplant. So you can see there 62%, 37% hearts, and very small numbers of heart-lung. And if you follow that little process map there, we can see that dysphagia was present in 88% of the patients that were actually referred to us. Now, we've got to think about this holistically, I suppose. These are the patients that were referred. So we're assuming that there's probably higher rates out there, and that patients, as we all know, slip through the gaps. Laryngeal dysfunction was also really high. And when we say laryngeal dysfunction, if you've got any SLTs on with us today, there's a broad range there. Obviously, that ranges from all the way from some, mild dysphonia, where patients just have a rough voice for a little while, and that resolves, all the way through to vocal fold palsy. And you can see the data there. The vocal fold palsy rates were 16% of the patients that we were referred, which is also quite high. What did the associations tell us? So these were the areas that showed significant association. And look, no major surprises, but still very helpful. So the patients that were in ICU for longer, so longer period of time in ICU, more frequent intubations, which is very common for us, longer intubation time and returns to ICU, were significantly associated with referral to speech pathology. So we can definitely see some patterns there in terms of, obviously, patients that stay longer in ICU are more frail, that, the frequency of intubation and the length of intubation were key factors there, which is pretty common when we think about the critical care literature as a whole. So what did we take away from that study? So obviously, high numbers of referrals. It's indicating there's a high risk there for these patients to develop these swallowing and laryngeal complications. And that most of the associations were between post-operative factors and the need for speech pathology. There wasn't really any association between the pre-operative factors we looked at for this piece. So that just really was great, but it gave us more questions than answers. And hence, this is where we are today. So this paper that Michael was referring to, which is the basis for this presentation, was actually my research team's idea of attempting to fill the gap for clinicians in this field, especially if they're kind of new to the field or they're working with these patients, but not specifically in the area of speech language therapy. Because there really is nothing in the literature to explain why these patients are having issues so frequently. So we were very pleased to have this paper recently published in Journal of Heart Lung Transplant. So what I'd like to do today is bring you through those contributing factors. We don't have a huge amount of time, so we'll go through them briefly, but just to give a bit of an overall concept of the issues for these patients and where they might result from. So those 6 factors that we've identified are the impact of critical illness or ICU acquired weakness, the altered respiratory status, the impact of altered neurology and polypharmacy often with these patients, recurrent laryngeal nerve injury potential, obviously that intubation piece that we have previously mentioned, and the gastric motility disorders that we frequently see in this population. So let's go through each one of those factors one by one. ICU acquired weakness. I mean, we all know that obviously impacts peripheral muscle strength and inspiratory and expiratory muscles and cough and voice. So all of those things send alarm bells, obviously, for speech pathologists, and also certainly is a predictor for reintubation, which makes us also concerned about the impact on laryngeal function for this population. Again, the data is very scant for the association between ICU acquired weakness and swallowing. There's a few good papers which I can certainly put you onto, but generally they report that there's high aspiration rates with these patients. And for those working in the field, that's certainly not surprising. However, we do tend to see, and this is certainly anecdotal, that as the critical illness weakness improves, the patient's swallowing function improves. But a lot more research to be done in this field. I mean, I'm even thinking along the lines of it would be really interesting to have a look at muscle strength and patients' aspiration risk, and whether we could predict their risk of aspiration based around, some basic muscle strength measures. So it'd be nice to work with our physios quite closely on that. In terms of the impact on respiratory status, this very much mirrors a lot of our other critical care patients. So in that we see, obviously, patients having high CO2 rates, low oxygen, and certainly a high respiratory rate. And we do know from the research out there that this definitely leads to a discoordination of the breath-swallow cycle, and certainly an increased risk of laryngeal penetration and aspiration. So this is a bit of a no-brainer for this population. Some of our American colleagues have actually published a paper just recently, I think it was last month, looking at cough dysfunction post-transplant and how that can impact on dysphagia. And they certainly found that the patients who were aspirating had a higher respiratory rate. So that's just further solidifies concerns in terms of patients' respiratory status and the impact they might have on their risk. The next factor we're going to briefly discuss is recurrent laryngeal nerve injury. So obviously we know there's a risk of injury during a surgery, but again, really poorly explored in this population. So we don't really know the true incidence. It is reported in the literature that the risk is greatest when removing the recipient's organs. And we do know that the left recurrent is at higher risk, obviously due to that deeper course in the chest. And that is substantiated with increased reports of left vocal fold palsy in the literature. Much higher rates are reported in lung transplant. Again, nothing in the literature to say why that is. So there's so many questions to be answered. And now, and I'm sure you guys are potentially seeing the same, we're kind of seeing a lot of patients developing vocal fold palsy following ECMO and also, you know, implantation of LVADs. So that's another field. In terms of intubation trauma, it's obviously going to be rife in this population, as I've previously touched on. Look, we know that laryngeal injury due to intubation is really high. Stat there of it being as high as 83% in ventilated patients. You're looking at obviously granulomas, vocal fold motion abnormalities, that whole spectrum from mild to severe dysphonia. And we certainly know that prolonged intubation is a predictor of dysphagia. And again, you know, we can't necessarily pull out what was certainly in Australia or in Sydney anyway, you know, what percentage of patients are presenting with these laryngeal dysfunction as a result of intubation, or whether it's certainly associated with the surgery at the time. And that's complex to draw that out. So let's have a look at gastric motility disorders. We know that it's pretty rife in this population. So obviously, patients are presenting with gastroesophageal reflux disease. They've got an increased amount of food and fluid in the esophagus. Then combined with the esophageal dysmotility, we know that these patients have results in that delayed clearance of that material. And then all the other factors. They're supine, they're sedated, they're immunosuppressed. Those meds that they're on obviously impact on the gastric motility. And on top of that, we're feeding them enterally. So every single one of those is a big risk factor for aspiration. So there's no surprise that we're looking at an association between the gastric motility issues and aspiration. And obviously there's a large body of research surrounding reflux disease and certainly lung transplant and the rejection issues there. And lastly, the other factor that we are considering is, you know, the impact of altered neurology in this population. So we're quite lucky in that, and I'm sure you guys are the same, we don't have a huge you know, incidence of stroke post-transplant, but certainly it's a risk and we do see it. We see a lot of delirium. Yeah, an ongoing issue for this population. And certainly we see some significant swallowing issues associated with that. All of the medications the patients are on, so, you know, resulting in xerostomia, certainly altered consciousness. And again, as I've mentioned, the impact on gastric motility of all these meds. And one of our colleagues, Miles et al., who is a speech language therapist in New Zealand, has published an excellent paper looking at drug interactions with lung transplant and swallowing. So all of these factors are really well known, as I said, to be associated with dysphagia and laryngeal dysfunction. So that's just taken us through those 6 contributing factors to give us a bit of a basis for, you know, why these patients are presenting with these issues. And that makes us start to think about, you know, well, are these temporary issues? Are they enough to worry about? Are they something that's just going to be, you know, naturally resolving throughout the patient's transplant journey? So in terms of prognosis and swallowing, that same paper, actually, Miles et al., does suggest that there is extended duration of swallowing issues. And look, this is what we see on the ground. Certainly, pretty much nearly every one of our patients is on enteral feeding for some point, for some time in their journey, and often on texture-modified diets. But, you know, we do tend to see resolution before these patients are discharged. Now, our journeys for our patients can be quite long. And I tend to see definitely the patients that are the ones that don't go so well, the ones that are reintubated, the ones that do have multiple complications, the ones that have infection, the ones that have, you know, rejection. So they may be in hospital for some months. But generally, we have very low rates of PEG insertion. So that's positive for the patients. But even still, that, you know, 3-month duration plus it can be 6 months, is a long time for these patients to be struggling with swallowing issues. And unfortunately, there's absolutely no evidence that we can see in terms of treatment for this population at this point in time. So in terms of prognosis and treatment for the laryngeal dysfunction, we certainly see recovery, but that's directly associated with severity. So the less severe dysphonias, and we're kind of hypothesizing that those are the ones that are struggling from an intubation trauma point of view. They tend to recover spontaneously. However, we're still heavily involved, generally treating these patients alongside the laryngologists where they have capacity. But, you know, certainly if there's laryngopharyngeal reflux, you know, as suspected, we're bringing in all those kind of medication and dietary and lifestyle modifications as well. That brings us on to looking at the patients that are certainly more severe and what do we do at St Vincent's for these patients. Look, it could be better, I will say, but how do we manage vocal fold palsy? Very much depends for us on the following factors. So how severe the injury is, how long we think it's going to recover, the patient's comorbidities certainly. Look, do they want to undergo further invasive interventions? Certainly some of our younger patients, yes. Some of the more elderly ones, no, they've had enough. And look, it depends on their transplant journey and how traumatized they are, I suppose. And yeah, whether it's a big issue for them going forward. You've got a big difference between somebody who's got potentially young children and can't voice versus an elderly gentleman who lives with his partner and isn't particularly social. So what I'm saying is there obviously we tailor our management to the patient individually. And it also certainly depends on, the local policy at the transplant centre. I know that my colleagues in New Zealand are very proactive with their vocal fold palsy management, and they certainly perform early medialisation procedures for their patients, which from my point of view and from a lot that's out there in the literature is very positive. We really want to maintain that glottic competence as much as possible. So yes. We don't tend to do that at the moment. We do, but not for every patient. So it depends. And, what might the patients want to do if they don't want to go for early medialisation? They might just want to watch and wait. And that's certainly fine. And we do offer that. But for those patients who are presenting with vocal fold palsy past about 6 months, we're certainly opening up the avenue for thyroplasty, which we tend to have fairly good outcomes with. Oh, that's just showing you one of our patients who had a cord palsy there so he's looking at obviously your abduction pre-injection laryngoplasty and then post, so AB versus CD. So as I mentioned, pretty much all the research that we've come across to date and the research we've done ourselves within our team has led us to more questions than answers. This is what we really want to know. Can we predict which patients are more likely to develop swallowing and voice complications? And will this enable us to intervene earlier? What is the incidence of pre-existing voice and swallowing deficits? And are they exacerbated when patients go forward to have transplant? And as I touched on, should we intervene early for cord palsy? So this is myself and a couple of my colleagues, and this is the prospective study that we're actually jumping off to do. It's a big piece of work, and like everyone else, we were largely affected with COVID. So part of this study, as I've mentioned there, is actually doing a fibroendoscopic examination of swallowing for all our patients that are recruited pre-transplant. So we've got the baseline measure. And then we're doing a number of post-operative data points as well. But our transplant clinic pretty much went online in COVID. So yeah, we weren't able to obviously scope our patients. And without that data, we decided not to proceed with the study because that was really, essential for what we wanted to know. So COVID numbers have thankfully dropped, or in terms of severity, patients are certainly not as unwell. So our clinic has opened up with business as usual at the moment. So we're starting to recruit again, which is very exciting. What do we want to know for this study? So basically, as I said, we really want to know the incidence before and after transplant. And we want to have a look at whether there's any association between the post-operative issues and any pre-operative risk factors we could identify. We also want to get some nice firm data about that prognosis piece. Where do these patients go? Is it only 6 months? Even though it could be a long time for patients. Is that, what's the duration of these symptoms for the majority of patients? And again, we want to know if swallowing and voice issues before transplant are associated with increased post-operative existence and the associating factors. Does this result in increased length of stay? Does this result in increased hospital costs? And is there an issue with or association with survival? So lastly, before we open up, hopefully we've got some time for questions, but where do we want this to go? And I suppose, when I'm looking forward, I think we potentially need within Australia as a whole, we need to look at the model of care for our patients. Do we include pre-operative workup as standard? Is that required? And that's what we're hoping this data will tell us. And what does that post-operative piece look like? Do we see every patient? Is it warranted? Or do we use a very strict clinical pathway that's based on the factors that we've determined from our studies? Do we need standard fibroendoscopic examination of swallowing? We know that silent aspiration is really high in this population. We don't do this routinely for every patient we would like to. We don't have the resourcing. We have the equipment, we just don't have the staffing levels at present. Work in progress. What's the optimal management of vocal fold palsy? How should we best be managing it? Should we be doing early intervention? And ideally, if we do come up with our ideal model of care, we'd like to have that taken up by other Australian transplant units. So we've got, consistency across and international collaboration, which is perfect in this forum. For anyone, just lastly, who's super interested in this, again, to fill that gap in the resources for patients working in the field, the University of Sydney has a program called the Dr. Liang Voice Program. which is a large voice clinic. And I work very closely with them as part of this research study. And what we're doing is developing some online education modules, or I'm developing some online education modules, which are going to be released. That is not been updated. It is not June 2022. It's more likely to be January of next year. But certainly reach out if you're interested in exploring those education modules in the future. That brings me to the end of the formal piece, but I'd love to open the floor up to any questions.
Thank you so much, Rebecca. It was really interesting, and something, and for me as a cardiologist, a lot of details and nuances to this issue that I don't tend to think of. So I really do appreciate this presentation, because like I had mentioned previously, as you alluded to with the data that you shared, this tends to bother in effect way too many of our post-op patients, and it does really lead to this really difficult post-operative course. And I do feel like these patients tend to be the ones that stay in the hospital for quite a long time after transplant, and obviously then they're more likely to develop complications because of the aspiration that you mentioned.
100%.
So it's really important work, and I'm really glad that you got a chance to share it with us.
Thank you for inviting me.
Yeah, so I know we've got some of our colleagues on the call, also from our local speech and language pathology department. So and some of my colleagues from the transplant group as well. So if anybody has any questions for Rebecca, please feel free to unmute yourself, and you can ask the question, or you can type a question in the chat and I can pose it for you, or you can raise your hand and I can call on you. And I'll just be quiet for a moment to give anybody a chance who would like to speak up.
Hi, thank you so much for the talk. It was very interesting. My quick question is, in your prospective trial, are you going to be looking at nutrition and frailty assessment prior to the transplant to see if there's a correlation with your outcome measure?
Excellent question, Lavanya. In terms of nutrition, yes. So we're going to be looking at and working very closely. So our workup clinic involves very strong multidisciplinary team focus. As I said, SLT is not usually involved, but we will be when we're recruiting these patients. So yes, we're looking at working quite closely with our nutrition colleagues. The study it's very large in that we have a huge number of variables that we're collecting, but we're certainly looking at nutritional status and certainly duration of enteral feeding throughout the patient's journey. In terms of frailty, not at this point. I'm very interested in that. So we haven't decided. We can access that data pretty easily. There's quite a lot of work being done in at St Vincent's in terms of frailty and the association with patient outcomes post-transplant. So yes, I'm quite interested in that, and I'm just trying to think about working with my colleagues as to how we might be able to look at that as one of our variables, because I think it would be a shame if we were to, look at many other things but not include that frailty piece, especially when we know the issues with ICU-acquired weakness post-transplant and are concerned about it at that end. So yeah, great point.
Thank you.
Anyone else?
Osvaldo has a question for you.
Hi, how are you, Rebecca? Thank you very much for the talk. It's a very important topic.
Welcome.
And I'm one of the cardiothoracic anesthesiologists and intensivists. So yeah, we always have in mind these problems, particularly in patients that have been intubated prior or have prolonged intubation times. Do you find significant, and I expect to have significant difference between the lung and the heart transplants incidence of the postoperative dysphagia. So, I mean, the management is very different in terms of number of intubations, number of reintubations, and the type of tubes that we use intraoperatively and the times that we have to exchange tubes. So you guys find that we're able to divide the data into those two groups to find the incidence. Was it significantly different, or maybe there's an intrinsic component that is not even within the choice of tubes or intubation on airway manipulation that causes postoperative dysphagia?
Excellent question. Not so far, because the previous studies have been, retrospective in nature, but absolutely. So we're going to certainly look at the difference between the outcomes for the hearts and the lungs, because, as you said, we recognise there's some different contributing factors. The literature to date tends to show us that lungs, we're seeing more issues in that lung population, which tends to make sense when we think about the association with respiratory function and swallow. But yes, it's very much still a work in progress. And hopefully, again, this prospective study will answer some of our questions about that. And if we're seeing, really large differences between those hearts and those lungs, why that is.
Thank you.
Any other questions or thoughts out there? I guess Lavi's got another question. Go ahead, Lavi. Sorry.
Just one thing that it caught my interest when you said that you're noticing increased vocal cord dysfunction with use of ECMO. I'm not entirely sure if I made that observation. Wanted to see your thoughts on why that would be the case.
Yeah, well, we don't know. And I think we've got a lot, certainly us, that we've got a lot of unknowns with our ECMO patients. We're doing quite a lot of pre-transplant ECMO over the last few years. So, I've thrown out a very anecdotal comment there, which we have no literature to support. So with this, again, it's not going to be the be all and end all, but hopefully we can look at that a little bit more closely with the prospective study as to why that might be. Yeah, because it's not answering, there's no, as you said, there's no potential obvious logic in that association. But with this population, there isn't a lot of obvious logic. I suppose when I often say to people that I'm working with swallowing and voice and transplant, and they kind of look at me and go, oh, like, why is that an issue? But yeah, I don't know why that is. So we need to look at them, because I think we're all going to be using, ECMO quite a lot, going forward. Certainly our patients tend to be, over the years, becoming a little bit more frail, and we're opening up our criteria a little bit more, more elderly patients coming through for transplant, etc. And so seeing, those increased ECMO, certainly pre and post. So yeah, it'll be interesting to look and see, if that is substantiated, if there is increased rates, and why that is.
So Rebecca, would you mind sharing maybe your email address with us all? Because maybe some of our colleagues from the speech and language pathology department might be more interested in reaching out to you directly through email and starting a
yeah, absolutely. I'll send it through to you, Michael, and you can, if you're happy to forward it.
Could you, well, I have your email. Could you just put it in the chat possibly, and then they could copy it from there if they want to send you a message later?
Rebecca, I don't have a question, but I just wanted to say thank you for the presentation. I'm a pharmacist. I used to rotate between caring for heart and lung transplants. And anecdotally, we saw a lot of swallowing issues in our lung transplants, to the point where all of our patients had swallow studies and fees after lung transplant. But our heart transplant program, we were just at a loss for which patients to target for intervention. So I'm very excited to see your work.
Oh, thank you so much. That's lovely. It's very, exciting to hear that. And I work very closely with our pharmacists, who are absolutely amazing, because we've got so many patients that have such big issues with swallowing their medications, especially the immunosuppressives. And it's like, how do we work around that? Because it's a no-brainer, it has to happen. So I love working with my my pharmacy colleagues, and I think we've developed a working relationship that we didn't even know was necessary, really, many years ago. We just kept finding that we were crossing paths so frequently to try and work it out together. So, yeah.
Thanks so much. So just so you all see, Rebecca did put her email address in the chat, rebecca.black@svha.org.au. And thank you again, Rebecca. So she's starting her Thursday while we're winding down our Wednesday here in the States. So have a great rest of your day. And thanks everybody for joining us, and have a good evening, everybody here stateside.
Thank you.
Thank you, everyone. It's great to see you all.